So the management of parathyroid primary hyperparathyroidism is we all know that the cause is adenoma or carcinoma. So surgery is the only definitive treatment. But if a person cannot undergo surgery, then cinacalcet, which is a calcimimetic agent that suppresses the PTH levels. Bisphosphonates can also be used to reduce the fracture or to reduce the risk of fragility fractures. And the best is if the patient is symptomatic. What are the symptoms of hyperparathyroidism? Two most important symptoms that you need to remember for hyperparathyroidism is renal stones plus fragility fractures. So in the Plab 1 exam, if someone present to you with fragility fractures and renal stones, then it is most likely primary hyperparathyroidism, and the only definitive treatment is parathyroidectomy. And if the person cannot undergo surgery, then cinacalcet. So history of fragility fracture plus kidney stones, laboratory evidence of primary hyperparathyroidism. So Dr. Sombal will tell us what is the laboratory evidence of primary hyperparathyroidism.
Sir, it's increased PTH along with increased phosphate.
Phosphate will be increased or decreased in primary hyperparathyroidism.
No, sir, decreased phosphate. It's secondary and tertiary, it will be increased.
Yes, that's right.
So
Parathyroid
PTH,
hormone.
yes, sir.
So can you repeat it, please?
First of all, the parathyroid hormone will be increased.
Yes.
And the phosphate level will be decreased.
And calcium level? What about calcium level?
And sir, with increased calcium level?
Yes, because PTH is high. PTH loves calcium and
Yes,
it
sir.
hates phosphate. So high PTH, high calcium, low phosphate. This is the laboratory evidence of primary hyperparathyroidism. So someone developed a disease, organ damage such as renal stone or fragility fracture, then the only treatment or definitive treatment is parathyroidectomy. Secondary hyperparathyroidism. The cause of secondary hyperparathyroidism is low calcium. Low calcium due to chronic kidney disease. So here the formula that the PTH loves calcium and it hates phosphate will not apply, because though it's hate phosphate, the kidneys are not there to excrete the phosphate. So in secondary hyperparathyroidism, PTH will be high, phosphate will be high. Low calcium or calcium will be low or normal. So person with a low calcium level and high PTH, then it means the cause is chronic kidney disease, or this is secondary hyperparathyroidism. The treatment is done with mainly vitamin D supplements, because it's the deficiency of vitamin D that led to the development of secondary hyperparathyroidism. So we will treat the cause such as vitamin D deficiency through vitamin D supplements, cholecalciferol or alpha calcidiol. Both of them can be used. Alpha calcidiol is more effective than cholecalciferol, so it is used in patients with severe renal impairment. If the calcium levels are low, then we need to add calcium supplements as well, along with vitamin D supplements. And if the phosphate levels are high, then we need to add phosphate binders as well. So for any patient with chronic renal failure, how a scenario of secondary hyperparathyroidism will present? A patient with a history of CKD or renal failure is calcium level will be low, PTH will be high, you will think of secondary hypoparathyroidism. Secondary and tertiary, both of them are caused by kidney diseases. So a female with breast cancer present to you with drowsiness and increased thirst, you will suspect hypercalcemia. And what is the treatment of hypercalcemia? What is the initial management of hypercalcemia? Dr. Shafraz will tell us. Initial management of hypercalcemia.
IV fluids.
Yes, IV normal saline. And what is the second line?
Bisphosphonate.
Bisphosphonates. Hypercalcemia can occur in squamous cell carcinoma of lung as well because of paraneoplastic syndrome, because of secretion of PTH by squamous cell carcinoma. So now some important points about hypercalcemia, how to differentiate between different causes of hypercalcemia. So remember that what to do when you suspect hypercalcemia. First of all, we will correct calcium. Corrected calcium is calculated through this formula, but this formula is not important to remember. In the Plab exam, they will give you corrected calcium level. So the first step is to correct calcium, and the second step is to check albumin. A person who present to you with hypercalcemia, how you are going to rule out different causes of hypercalcemia. The first thing that you need to do is check his albumin level. If albumin level are high and urea is high as well, then the cause of his hypercalcemia is most likely dehydration. So a person presented to us with hypercalcemia, the first thing that we did was to check his albumin level. Albumin level were high, urea is also high, calcium is also high. The cause is dehydration. Everything is high means the cause is dehydration. Now, in the second step, we'll check his ALP level, alkaline phosphatase level. High calcium with high ALP. Three things you should consider, or three things you need to keep in your differential diagnosis. One is thyrotoxicosis, one is sarcoidosis, and the other one is bone metastasis. So hypercalcemia, in the first time we checked albumin. If albumin is high, then the cause is dehydration. In the second step, we checked ALP, high calcium with high ALP. Three things you need to remember in this scenario, that is thyrotoxicosis, sarcoidosis, and bone metastasis. In the third step, we'll check calcitonin level. If calcium is high and calcitonin is high, then it is B-cell lymphoma. So this slide is very important to remember because this is a favorite question of the examiners of the Plab 1. How to diagnose the cause of hypercalcemia. Hypercalcemia with, yes?
Sir, you will also provide the notes of these? Or we should
I
write
have
it?
shared the notes of endocrinology on the group.
Already
I have
shared.
already shared it. Yes.
Thank you, sir.
But it is given in the Plab 1 keys as well.
Okay, sir.
But I tried to write all the causes of hypercalcemia and raised ALP on one slide. So it will be better if you do it from here. So high calcium, high albumin, dehydration, high calcium, high ALP, three things: thyrotoxicosis, sarcoidosis, bony mets. Bony mets can be due to breast cancer. It can be due to prostate cancer. It can be due to multiple myeloma. Three malignancies you need to remember for bony mets.
Sir, this you are talking for calcitonin?
What?
Sir, the tumors which we are saying, these are in perspective of
These are for high calcium and high ALP.
ill. Okay, sir.
High calcium with high calcitonin, only one diagnosis, and that is B cell lymphoma. Along with these three steps, you need to remember these three diseases as well. If everything is normal, calcium normal, phosphate normal, ALP normal, and the person is having bone pain, then your diagnosis will be osteoporosis. Normal calcium, normal phosphate, only high ALP, Paget disease of bone. Because in Paget disease of bone, due to some genetic defect, there is problem in the bone formation. So that's why normal calcium, normal phosphate, but high ALP, Paget disease. Now, the third diagnosis is osteomalacia. Osteomalacia is basically deficiency of vitamin D. So in vitamin D deficiency, calcium and phosphate will be low, but ALP will be high. So this slide is very important to make a diagnosis of all these conditions: dehydration, B cell lymphoma, thyrotoxicosis, sarcoidosis, bone mets, Paget disease, osteoporosis, and osteomalacia. Is this point related to calcium clear to everyone?
Yes, sir.
Yes, clear. But sir, could you please explain the relationship ALP has with hypercalcemia?
Okay. Alkaline
In
phosphatase
general,
yes, alkaline phosphatase or ALP uh, is an enzyme that is present in bones, and as well as it is present in the biliary tract, in the cells of the biliary tract as well. And it is also secreted by placenta. So in three conditions, it can be raised. What are those three conditions? One is if there is problem with the bones. The second is if there is problem with the biliary tract, such as obstructive jaundice or cholelithiasis. And the third one, during pregnancy, it can also be raised. So here we are talking about the bone. So in the bones, the alkaline phosphatase is secreted by osteoblasts or the bone forming cells. So whenever the activity of the osteoblast is high, ALP level will also become high. So now let's analyze different conditions in which ALP is high, such as now there are some conditions in which hypercalcemia with high alkaline phosphatase. So in thyrotoxicosis, there is increased bone resorption. In sarcoidosis, due to increased formation of calcium, due to increase formation of active form of vitamin D, calcium level increases, and which lead to an increase in the bone turnover by the osteoblast cells. Similarly, in the bony metastasis, the similar things happen that osteoblast cells try to form new bone because of metastasis of cancers to the bone. Osteoblasts try to recover these bone cells. So the activity of the osteoblast is increased, which leads to an increase in the ALP. Now, in osteomalacia, there's deficiency of vitamin D, which leads to a deficiency of calcium and phosphate. Now, due to low levels of calcium and phosphate, osteoblasts are stimulated because if osteoblasts are stimulated, they will stimulate the osteoclastic cells. And the osteoclast will lead to bone resorption and it will try to increase the level of calcium and phosphate. So that's why ALP level again will be high in osteomalacia. And in Paget disease, there's a problem with the bone formation cells due to genetic defect. That's why again it will be high in Paget disease. But in osteoporosis, due to deficiency of some enzymes such as estrogen in old age females, there is usually bone resorption and no increase in activity of osteoblast or osteoclast, so the ALP will be normal.
Got it, sir. Thank you.
So a short summary of these disorders. High
So the
calcium with high,
the phosphate, why is it normal in Paget disease?
because there is no problem with calcium, phosphate, or vitamin D in Paget disease. The basic abnormality in Paget disease is that due to genetic defect, there is problem with the bone forming cells and bone dissolving cells such as osteoclasts.
Okay.
That is basically a genetic disease. It has nothing to do with calcium and phosphate.
Thank you.
So a short summary of these disorders: high calcium, high ALP; high calcium, high alkaline phosphatase, three condition: thyrotoxicosis, sarcoidosis, bony mets. Simple. High calcium, high ALP, these three condition: high ALP and normal calcium and phosphate, Paget disease; high ALP and low calcium and phosphate, osteomalacia. Is it clear, everyone?
Yes.
And all the things normal osteoporosis. Multiple myeloma is also a type of malignancy that can present with hypercalcemia. The signs and symptoms of hypercalcemia we have already discussed. Moans, groans, bones, and stones. Management also discussed. So if a patient of prostate cancer, of breast cancer, and multiple myeloma present to you with features such as increased thirst, polyuria, polydipsia, confusion, depression, kidney stone, bone pain, then the initial step is to check his serum calcium level. And if he is diagnosed with hypercalcemia, then you will manage his hypercalcemia through IV fluids and bisphosphonates. So, who will repeat the causes of or the relation of calcium with alkaline phosphatase and their diagnosis based on their finding. Dr. Abdullahi, can you do that?
Sorry, Doc, what did you say?
I'm asking about the relation between ALP and calcium and a differential diagnosis based on them. Which condition will lead to high ALP and high calcium?
Paget's disease?
High calcium and high ALP.
High calcium and high ALP.
Yes.
Sorry, I'm not sure.
High calcium and high ALP. Three conditions: thyrotoxicosis, sarcoidosis, and bony metastasis. Can you repeat them?
Yes, sarcoidosis, thyrotoxicosis, and the third one you said bone metastasis.
Yes, bone metastasis is an important one to remember. Because when there is bone metastasis, calcium level will increase and ALP will also increase because of the bone destruction by the tumor cell. So this is a way by which you can remember that high calcium and high phosphate bone metastasis. High ALP with normal calcium. What is the diagnosis? Who will tell me this one?
Is it Paget's disease?
Paget's disease.
Yes, Paget disease, because in Paget disease, there is no problem with the calcium or phosphate. There is problem with the bone formation, the way the bone is formed. So that's why ALP with normal calcium is Paget disease. High ALP with low calcium. What is the diagnosis?
Malaysia.
Malaysia.
Osteomalacia, that's right, excellent. Because of vitamin D deficiency, low calcium level, and the body will try to increase this calcium level by stimulating the osteoclast cells, and osteoclast cells are stimulated by the osteoblast cells, and osteoblast cells releases alkaline phosphatase. So low calcium with high ALP is osteomalacia. Every chapter in Plab 1 has one or two such topics which need repeated revisions, and this is one of the topics in endocrinology that need to be repeated again and again. So February Plabbers can write this on a page and just revise them daily for 5 minutes. So osteomalacia is due to deficiency of vitamin D, and due to deficiency of vitamin D, calcium and phosphate will be low and ALP will be high. Alkaline phosphatase is released by the bones, by the biliary tract, and during pregnancy. We have all discussed this points. Hypoparathyroidism. Hypoparathyroidism, the most common cause of hypoparathyroidism is surgery or after surgery, after thyroid surgery. Hypoparathyroidism is usually a rare condition, so it usually will not be tested in Plab 1 exam, but still you should know the cause of hypoparathyroidism, and that is post thyroid surgery. Now, hypoparathyroidism. What is pseudo hypoparathyroidism? Pseudo means false. Hypoparathyroidism means hypoparathyroidism. In pseudo hypoparathyroidism, it is a genetic condition in which there is a resistance to the or insensitivity to the PTH, parathyroid hormone. The target cells or the receptor cells are insensitive to PTH. So the person will have low calcium, high phosphate, and high PTH. Low calcium because the target cells, such as, for example, the kidney tubules, though the PTH levels are high, the PTH level are normal or high, but the cells are insensitive to PTH. They are not listening to PTH. And what does PTH do? It causes a reabsorption of calcium and increase excretion of phosphate. But when the cells are insensitive to PTH, then what will happen? Calcium will not be reabsorbed, so low calcium, and phosphate will not be excreted, so high phosphate, and PTH level will be high. Why PTH level will be high? Due to low calcium, because low calcium will stimulate more production of PTH. So someone with these features, with low IQ, short stature, and shortened fourth and fifth metacarpals, your diagnosis will be pseudo hypoparathyroidism. It is hypoparathyroidism, remember that, not hyper. Though the PTH levels are high, but it's still hypoparathyroidism. How to diagnose pseudo hypoparathyroidism? Pseudo hypoparathyroidism is very simple to diagnose. The person will have low calcium, high phosphate, which is a feature of hypoparathyroidism, but PTH level will be high. And the other symptoms will be low IQ, short stature, and shortened fourth and fifth metacarpals, because pseudo hypoparathyroidism is a genetic disease. The last topic of endocrinology is multiple endocrine neoplasia or MEN syndrome. MEN is an autosomal dominant disorders. Remember the rule of P's: parathyroid, pituitary, pancreas. They form MEN type 1. This is a pure cramming. So MEN type 1 has 3 P's: parathyroid, pituitary, and pancreas. Parathyroid secreting tumors such as hyperparathyroidism, feature of hyperparathyroidism, pituitary adenomas, and pancreatic hormone secretion such as insulinoma, gastruloma. So 3 P's is MEN type 1, 2 P's MEN type 2A, parathyroid and pheochromocytoma, and a medullary thyroid cancer as well. And 1 P is MEN type 2B. So very simple to remember. 3P is MEN type 1, 2P is MEN type 2, and 1P is MEN type 2B. So this was all about endocrinology. We are done with the endocrinology. If someone has any question, he can ask.
Can I just take the screenshot of that, please? If you can just scroll it down. Yeah, further up, please. Thank you.
So this was all for today. There will be no class tomorrow, and as well as a day after tomorrow. We'll have our next class on Monday. Uh, on Sunday, I have a duty, and tomorrow I'll be busy in doing some work. But for Plabbers, I am available tomorrow if they want to ask anything or they need to discuss any topic. They can let me know in the group, and then I can take some time out for them. Otherwise, we'll have our next class on Monday, and we'll start with gynae and obstetrics. So I'll see you guys on Monday. Until then,
Okay. Take care, Doc. Thank you.
Okay, sir. Thank you.
Allah Hafiz, good night, and take care.